Excellent. Okay, next up is Dr. Simon Johnson from University of Washington. Title of his talk is Immune-Mediated Disease Pathogenesis in Leigh Syndrome.
All right. Hey, Ethan, can you see my slides?
Yes. Everything looks good.
Perfect. All right. Just want to quickly thank Casey and the rest of Cure Mito for inviting us to be part of this today. And of course, thank everybody who's in attendance for taking time to listen to these lectures. So I'm going to talk today about what we think in my laboratory is some sort of breakthrough work in our understanding of the pathogenesis of mitochondrial disease. This is sort of a hybrid talk for a hybrid audience. It's maybe a little bit topical for the scientists here and maybe a little bit in depth for some of the lay people. So I want to emphasize that we have some additional resources available for anybody who listens to this talk and wants to learn more. My laboratory website is just johnsonlab.science. Feel free to email me. My email address is right here. And the bulk of the work that I'm going to talk about today is published, and these papers are they recently have come out and they're open access, publicly available. So feel free to look these up, give them a deep read through at your will. All right, so my laboratory is deeply interested in elucidating the mechanisms underlying the pathogenesis of mitochondrial disease. So our real belief, kind of our mode of operation is we think that we know a lot about how mitochondria work. We know a lot about how individual proteins in the mitochondria function, but we really don't know how defects in genes that encode mitochondrial proteins actually lead to the complex syndromes that we see in human patients. We work in a lot of models, but the one I'm going to talk about today, the one we spend most of our time in, is Leigh syndrome. This is, as you know, as you've heard about through multiple talks today, the most common pediatric form of mitochondrial disease. It's early onset, typically around 2 years of age, symptoms begin to show. It's a multi-organ syndrome. It includes muscle weakness, lactic acidosis, respiratory failure, seizures, and a lot of other symptoms. The real hallmark symptom of Leigh syndrome, however, is the appearance of symmetric lesions in the brain stem and other parts of the brain. Cortex is generally spared, and importantly, lactate is often visible in MRI, MRS imaging of these lesions. There are no clinical interventions available yet. We study Leigh syndrome largely using a mouse model called the NDUFS4 knockout mouse. This mouse closely resembles human Leigh syndrome, including the causal defect. So these mice have a defect in the same gene that can cause human Leigh syndrome. It's not, of course, the only gene that can cause Leigh syndrome, but it's one of the genes that can cause Leigh syndrome. As in humans, these mice are born normal, overtly normal without disease. They have a postnatal disease onset, rapid disease progression, and they show all of these same symptoms, including critically these symmetric CNS lesions, and they occur in the same exact parts of the brain in the mouse as they do in humans. This is just a quick picture to show you how we look at these lesions in a mouse brain. This is a part of the brain stem that we've stained with antibodies that mark inflammatory cells, microglia and macrophages. Those are in red here, and astrocytes. These are a supportive cell in the brain. They also respond to damage. These are in green, and you see this really huge neuroinflammatory lesion that we would typically describe as having astrocytosis and microgliosis because of the accumulation of those two cell types. So in this mouse model, progression is very rapid. As I mentioned, they're born healthy and normal. They have a sort of transient hair loss phenotype, which isn't really related to disease. And around P35, postnatal day 35, when they reach sexual maturation is when disease sets in. Rapidly after that age, they begin to display weight loss, which we call cachexia, clasping, ataxia, and circling. These are all just signs, visual signs of neurological dysfunction. And mortality in this model without intervention is by about 80 days. You can kind of think of the lifespan of this animal as two phases: no overt disease before P37, rapidly progressive neurodegenerative disease after that age. So the work I'm going to talk about today is follow-up studies to a body of work that we did back in 2013, 2014, where we found that inhibition of a particular set of proteins, which together are called mTOR, significantly extended survival in this mouse model of Leigh syndrome. It wasn't a full rescue of disease. However, at the time, it was the first small molecule drug ever shown to significantly attenuate disease in mitochondrial disease animal model. So it was quite exciting. mTOR, just a real quick intro to it. It stands for the mechanistic target of rapamycin. It's a set of proteins, a very large set of proteins that form a complex inside the cell, and they act as a hub for signaling. So they get cues from all sorts of different inputs, and they synthesize them and regulate a bunch of outputs, as you can see in this really simplified diagram here. Really what they're regulating is cues for appropriate environment for growth and proliferation for individual cells, and regulating the processes that drive proliferation versus maintenance. Thinking of mTOR in kind of the cellular context, it lies inside the cell. A lot of the signals that feed into mTOR arise from within the cell, such as amino acids, energy level, favorable conditions, but a lot also come through at the cell membrane through extracellular signaling. Some forms of signaling include insulin signaling, growth hormone signaling, things like that. So these are factors that bind something at the cell receptor, induce signaling inside, which activates mTOR. So again, we found that blocking mTOR rescued disease, but at the time we didn't know what the mechanism was. So why have we been going after this for the past nearly a decade? Well, our rationale has been that if we can determine the role of mTOR in these findings, how is it that mTOR inhibition is rescuing disease? Perhaps we can uncover some more basic mechanisms of the disease itself and maybe identify some more potent targets for intervention. So, as I mentioned, this is something we've been working on and off for nearly a decade. Our lab, as well as a number of other laboratories. And what ourselves and a number of other groups have kind of been doing is over the past few years is we've been looking downstream of mTOR and systematically looking at all the different things that mTOR regulates and kind of testing them all to see which one of them might be responsible for the benefits we saw. And after all this work, the overall result that we came to, the overall conclusion was that it didn't seem like any one of these pathways was by itself responsible for the benefits of mTOR inhibition. Some of them provided some very, very modest benefits, but nothing was really profound. So recently we started thinking about this a little bit differently. We decided to think upstream. What if the role of mTOR is not defined by what it's doing, what's downstream of it, but rather by what is activating it upstream? What if one of these inputs going into this complex of mTOR defines the role of mTOR in the setting of mitochondrial disease? We tested a number of these, and I'm going to kind of skip through all that to hone in on the one that became interesting, which is signaling through the cell membrane bound receptors, signaling through receptor tyrosine kinases in particular, which signal through PI3 kinase. So it's not important to remember all of the names of these players. Just remember that the cell membrane has receptors in it, and factors from the outside can bind to them and induce signaling on the inside. And through this particular set of pathways, through PI3 kinase and receptor tyrosine kinases, PI3 kinase mediates signaling to mTOR through those signaling factors. So when we decided to look at PI3 kinase, we initially realized that there are really 4 forms of PI3 kinase itself. They're defined by the catalytic subunit. There's an alpha, a beta, a delta, and a gamma. And fortunately, there are highly selective pharmacologic agents for each of these. So we can treat animals with mice with a drug that targets just one of these really specifically and see what happens. When we did those experiments, we found that the alpha, beta, and delta PI3 kinase forms, inhibition of them essentially did very little to nothing in terms of disease progression in these animals, whereas inhibition of the PI3K gamma isoform was extremely promising. In fact, the benefits that we observed were on par with what we saw with mTOR inhibition with rapamycin. And you can see in this lifespan curve here of animals treated with the PI3K gamma drug that it overlays quite well with the mTOR inhibitor rapamycin. We also saw a rescue of disease in the animals, and these are just two of the kind of measures of disease state that we looked at. One of them is performance on a rotarod assay. This is just an overall measure of kind of coordination and muscle capacity. The PI3K gamma inhibitor treated animals performed better for much longer, including past the age when untreated animals would have all been euthanized. And cachexia, or weight loss, you can see there's a significant delay in the onset of weight loss in these animals as well. We also saw similar delays in clasping, circling ataxia. You can pull up the paper to look at those if you'd like. So what became immediately interesting to us was that this isoform, the PI3K gamma isoform, what's known about it is that it's really kind of specific to the immune system, and it's involved in leukocyte activation and proliferation, whereas the other factors are involved in other types of signaling. The question that comes out of that observation is, what if mTOR inhibition is simply rescuing disease through impairing leukocyte proliferation? If this is the case, would targeting the immune system directly provide an even greater benefit? And this is getting into kind of the take-home message of the talk, which is that the evidence was starting to suggest that Leigh syndrome may be an immune-mediated disease. So to test this directly, we decided to treat animals with a drug that would hit leukocytes very potently and specifically, and we picked the drug pexidartinib. This is a pan-leukocyte inhibitor. It depletes all cells that are CSF1 receptor dependent. This is a particular immune cell receptor at the membrane. We could talk for hours about CSF1 receptor and its complexities. Just know that it depletes immune cells, that it depletes leukocytes, in particular macrophages and microglia. What we found was that treatment with this drug fully suppressed the CNS lesions in this animal model. Here on this slide, you can see on the left, an untreated mouse at P78 towards the maximum lifespan, a very large lesion in the brainstem. On the right here, a pexidartinib treated animal at nearly 200 days, complete absence of lesions. We also saw a rescue of neuroinflammation in the cortex, which hadn't previously been reported in this model with treatment with pexidartinib. And this was a rescue of both the microgliosis, which I mentioned, and the astrocytosis. So both forms of neuroinflammation were prevented by treatment with pexidartinib, fully suppressed. We looked at a number of functional outcomes of brain activity. This is one example. This is whole body plethysmography, which looks at the ability of the brain to regulate breathing pattern. This is controlled by the part of the brainstem that degenerates in Leigh syndrome. Treatment with pexidartinib fully suppressed respiratory dysfunction in this model. It prevented gasping phenotype and allowed these mice to breathe normally and respond to hypercarboxic stresses completely normally. We also saw a rescue of exercise tolerance and ability on the rotarod, as previously mentioned, prevention of ataxia onset, and at least at an early age, P30, we also seem to see a rescuing of seizures, at least in this sort of low stress model, exercise-induced seizure model that we use. This may not carry over to other more kind of severe epileptogenic stimuli, but at least for this kind of mild stimulus for seizures, pexidartinib treatment seemed to prevent seizures. Strikingly and sort of unexpectedly, in addition to all these rescues of neurological dysfunction, we saw prevention of a number of signs of metabolic dysfunction as well. So cachexia, weight loss, was prevented, progressive hypoglycemia was prevented, and increased blood lactate levels in response to either a glucose stimulus or anesthesia. In both cases, treatment with pexidartinib, this leukocyte inhibiting drug, prevented them. And coming up on the end here, just to show you a quick video, because it's always more valuable than words. On the left, you can see about a 50-day-old end-of-spore knockout untreated, severely ataxic, uncoordinated. On the right, you can see some 150-day-ish old pexidartinib treated knockouts. The one real off-target effect of this drug is that you can see here is that it turns your hair white. It does the same thing in both mice and humans. So these are the same type of mice, but they've been on this drug for a while, so their hair and coat has turned white. Lastly, we saw a substantial rescue of survival. This seems to be limited only by toxicity of the drug, as control animals treated with the same dose were dying at about the same age as the end-of-spore knockout disease model treated with this drug. And you can see that in the cause of death as well. The majority of animals that are untreated are euthanized due to weight loss or severe neurological signs, whereas the pexidartinib treated were all dying of unknown cause without any severe disease present. So we think we found the right target for treatment. However, this particular drug is toxic, and so we need to find a better target, a better agent. So just to give you some quick conclusions, this data suggests that at least a subset of symptoms in Leigh syndrome, the ones that we looked at, appear to be immune mediated. Disease might be attenuated with, or disease can be, as we've shown, attenuated without targeting ROS, energetic redox metabolism, or mitochondrial function at all. And this data really suggests that determining the key immune pathways involved might yield novel intervention strategies, perhaps more potent strategies and less toxic strategies. So just like to thank my lab really quick. Thank again the organizers for inviting me to talk. I'm happy to take questions when we get to the discussion period.
Thank you so